Hi there, my name's Connor Narovic. I'm the OSU EMS fellow this year, and today we'll be talking about some heat and cold emergencies, as it's getting to that point in Ohio where you can see multiple seasons all within the same day. Just to briefly outline what I'll be going over with you, initially we'll talk briefly about some thermoregulation and pathophysiology, how your body manages heat and cold normally, and then we'll get into some quick cases to consider regarding both heat and cold emergencies. Because of the delicate balance of sensitive chemical reactions that are necessary to maintain life, the human body requires a relatively narrow temperature range to function properly. For example, once your temperature starts getting above about 108 degrees Fahrenheit, the cell's ability to use energy sources that it relies on is disrupted, and the enzymes that maintain the ion gradient necessary for the heart and nerves to function stop working, leading to the expected seizures and altered mental status that you see in heat stroke. Temperature is set and regulated by a part of the brain called the hypothalamus, which controls various mechanisms in the body to increase and decrease heat production and loss, depending on the desired effect on temperature. For example, to reduce temperature, this would be peripheral vasodilation to shunt hot blood from the core to the cooler periphery, where evaporation from sweating can provide further cooling. On the other hand, if the body wants to increase your temperature, it will do the opposite, causing peripheral vasoconstriction to lessen heat loss in cooler extremities and shunt blood back to the core, where shivering can produce heat from chemical reactions that lead to muscle movement. Unfortunately, these mechanisms can be overcome by environmental extremes. The ability to cool by sweating disappears as the relative humidity approaches 100%, and the ability to cool by vasodilation disappears as the air temperature grows hotter than the skin temperature. This is why measurements such as the wet bulb globe temperature and heat index are used to give an idea of the risk of heat injury. Wet bulb globe temperature, which uses measurements from three different types of thermometer to estimate actual experienced temperature, takes things like humidity, cloud coverage, air temperature, and wind speed into account, and is most relevant for athletes. The upper table that you're seeing here is actually pulled from the Ohio High School Athletic Association's website and has practice activity recommendations on it that are based on heat risk as calculated by the wet bulb globe temperature. Heat index only takes humidity into account, and is actually measured in the shade, but is still a good marker for heat risk exposure for patients such as the elderly who might be stuck inside. On the other hand, for cold exposure, things like wind speed are much more relevant as they lead to increased heat loss from convection due to wind chill. Of note, as the body becomes increasingly cold, the efficacy of something like shivering to produce increased temperatures is significantly decreased. So now that we've gotten the biology stuff out of the way, we can actually get to some cases. For these, just read through and consider what you would do for these patients. If you've got folks that are watching the video with you, you can kind of chat over the questions that I put at the end to provoke thought. So in this first case, you're called to a local cross-country meet for a collapsed athlete. Upon arrival, you find a 17-year-old male surrounded by coaching staff and teammates. He appears confused with a GCS of 10. One of the coaches tells you that he may have had a seizure shortly after he collapsed. You check his vitals, and his heart rate is 124, blood pressure 105/70, respir's 28, satting well on room air, and you get a rectal temp, which is 106 degrees Fahrenheit. So some questions to consider: is this heat exhaustion or heat stroke, and why? And then if one of the trainers comes up to you and tells you that they have an ice bath available in a nearby first aid tent, would you take the patient to the ice bath to cool before you would transport them to the hospital, which is maybe about 20 minutes away? And if you were to just transport this patient, how would you consider cooling them in the back of the ambulance? The spectrum of heat-related illness runs the gamut from benign, if annoying, conditions like heat rash, heat edema, and heat cramps, which will resolve just by moving the patient into a cooler environment and providing a little rehydration, to truly life-threatening conditions such as heat stroke. The previous case is a classic example of exertional heat stroke, which is defined as severe hyperthermia, usually with a core temp greater than 104 degrees Fahrenheit, accompanied by evidence of CNS dysfunction. And this might be something as subtle as just impaired judgment, or as profound as coma or even seizure. This is contrasted with heat exhaustion, which presents with an elevated core temp, often of about 104 degrees Fahrenheit, but without evidence of actual CNS dysfunction. Differentiating between these diagnoses is important, as heat exhaustion is relatively mild and usually resolves with cessation of exercise, moving the patient to a cool area or providing them with oral rehydration, whereas heat stroke is a true emergency that can be complicated by multi-organ failure and a high risk of death and morbidity, being the third highest cause of death among athletes behind head and cardiac injuries. It's important to note that these diagnoses exist on a spectrum, and there is some overlap between their presentations, but given the high mortality of heat stroke, assuming the worst is very reasonable in these cases. As with all patients, the initial evaluation begins with assessing ABCs. While some amount of tachycardia and hypotension can occur with heat stroke, profound hemodynamic instability is much less common outside of a rare arrhythmia. Tachypnea is very commonly seen in heat exertional illness, but rarely represents true respiratory distress, with the chief threat to airway really coming from altered mental status, especially in the context of seizures, as we're concerned this patient may have had. It's important to note that all non-rectal temperatures are highly prone to inaccuracy in this patient group, and rectal temp is the gold standard for diagnosis of heat stroke. Uh, Temperature reading of less than 104 from an oral tympanic or cutaneous thermometer really should not provide you with much comfort. And because of the high risk of a significant morbidity or mortality event in these patients, if you're unable to obtain a temperature, but the history and presentation are consistent with exertional heat stroke, i.e., a young athlete that collapsed on a hot day while exercising, the safest option is to assume an elevated temperature and proceed with treatment for heat stroke. While less common in young athletes, always consider hypoglycemia as a cause of altered mental status and seizure. And while arrhythmia can occur in exertional heat stroke, it is relatively rare. That being said, cardiac dysfunction is the highest non-traumatic cause of death in a collapsed athlete, and so an EKG should be obtained in all these patients. It may feel counterintuitive to keep a patient with exertional heat stroke on scene so that you can put them in a tub full of water, especially one who may have just had a seizure. This is actually what is recommended for these patients, with a few caveats. The reasoning behind this comes from several studies that have investigated the effect of timing of cooling on outcomes. Though these studies are small and somewhat limited, increased mortality has been noted in patients where cooling was delayed even as little as 30 minutes. Obviously, if the patient is having an ongoing life threat that can't be addressed prior to immersion, for example, status epilepticus, an arrhythmia, severe agitation that isn't responding to initial IM meds, cooling should be bypassed and they should be taken directly to the hospital, but otherwise they should be cooled as soon as possible. Multiple techniques for cooling have been trialed, but the best technique has been consistently shown to be whole body immersion in cool water. This technique produces cooling at an average rate of about 1 degree Fahrenheit every 3 minutes, and conveniently, cooling tubs and ice baths are often available at high school and college athletic events. The patient should be completely stripped prior to immersion, if possible, to facilitate cooling, and as these patients by definition have altered mental status, they should be carefully attended by multiple people while being immersed. To prevent their head from going underwater and to facilitate quick removal from the tub if needed, a towel or sheet can be wrapped around the chest and under the arms. The patient should remain in the tub until their rectal temp has dropped to 102 degrees Fahrenheit, a threshold that's selected to prevent overshoot and subsequent iatrogenic hypothermia. Ideally, temp is continuously monitored, but you're unlikely to have access to the specialized equipment required, so taking repeat rectal temps every 3 to 5 minutes along with continuous repeat vital signs is reasonable. If you are unable to measure a core temperature but have high suspicion for heat stroke and are doing immersion cooling, your best option is to do continuous immersion for approximately 15 to 20 minutes, which will allow for a drop in temperature of about 5 to 7 degrees Fahrenheit. If no purpose-built cool water immersion tub is available, then they can be jerry-rigged using a variety of different techniques, for example using tarps or even body bags filled with ice water, which have been shown to have similar efficacy to the purpose-built tubs. If none of these cooling options are available, or there is another reason that cooling on scene is untenable, then the best option in the back of the ambulance is likely to be completely stripping the patient and placing ice packs over the patient's body. Classically, this is in the groin or axilla, though more recent studies have shown that perhaps placing the ice packs on cheeks, palms, soles, areas where there's no hair on the body is actually more effective. Additionally, the patient should be sprayed with water over their whole body, and the AC and fan should be turned up as high as possible in the truck. As the patient is being cooled, it's reasonable to obtain IV access. Many of these patients will be somewhat dehydrated at least, and this will ease administration of any medications needed if complications do arise. Once the patient has been adequately cooled, they should be transported to the emergency department. While exertional heat stroke is often very evident from the history, it's important not to forget other possible causes of the patient's presentation. For example, the most common life-threatening causes of a collapsed athlete include trauma to the head or cervical spine, cardiac arrhythmias, and exertional heat stroke. These can be remembered with the mnemonic heart, head, and heat. Moving on now to the second case. You're called to a residence for an ill person during the middle of a heat wave. On arrival, you're greeted at the door by the patient's daughter, who tells you that she hadn't heard from her mom for a few days and so checked in on her. She initially found her to be completely unresponsive, but now she is just confused. However, this is completely off of her baseline. She has a history of diabetes, cabbage, and alcohol use disorder. When you enter the home, you notice that it's very hot and there's no air conditioning. You find the patient to be a 78-year-old woman sitting in her recliner. She is confused to you as well with a GCS of 11. Her skin is warm to the touch and dry. Vitals are heart rate of 124, mildly hypotensive, respiratory rate of 28, satting low on room air, and with a rectal temperature of 106. What diagnoses are in your differential for this patient, and how would you pursue cooling in this patient if you would do it at all? This case is meant to be a presentation of classic non-exertional heat stroke. As opposed to exertional heat stroke, which occurs mostly in young, otherwise healthy athletes, non exertional heat stroke classically occurs in elderly, socially isolated, and immobile patients, especially during heat waves and especially with those who don't have access to air conditioning. Certain medical conditions, such as diabetes and alcohol use disorder, are risk factors, and many classes of medications, including antidepressants, diabetic medications, allergy medications, can predispose to vulnerability. While the definition of heat stroke remains the same, an elevated core temperature above about 104 degrees Fahrenheit with altered mental status in the setting of heat exposure, it is often impossible to make this diagnosis with a high degree of certainty in the field. As can be seen from the table here on the right, there is a significant overlap with the presentation of a number of other medical emergencies, especially in this higher risk patient population. This muddled presentation increases the likelihood of you anchoring on heat stroke and missing other important diagnoses, or doing the opposite and failing to consider heat stroke in the right clinical setting. Ultimately, the care of these patients should be very similar to any patient who presents with altered mental status, focusing on threats to the ABCs, assessing for signs of neurological stroke or trauma, treating seizures, treating agitation or intoxications that could be contributing to hypothermia. However, once these life threats are addressed, it is important to initiate cooling as soon as possible in a patient where non-exertional heat stroke remains high in the differential. Unlike exertional heat stroke, more conservative cooling measures, the ice packs on the body, misting with water, using high settings on the AC and the fan in the back of the ambulance, are considered the best place to start while the patient is being transported to the hospital for further workup and management. Summarizing what we've learned about heat emergencies. Heat certainly can cause a number of annoying conditions, most of which resolve with cooling off and proper hydration. However, heat stroke is a true emergency and carries with it a high degree of associated mortality. Heat stroke is defined as an elevated temperature with altered mental status, as opposed to something like heat exhaustion, which is elevated temperature with just symptoms of discomfort. While all presentations should start with addressing the ABCs in heat stroke, the most important thing is cooling the patient as soon as possible once they have otherwise been stabilized. Moving on now to talk about cold emergencies. Since our last two cases, time has passed and fall is gone and now it's winter. You're called to a local business for an unresponsive person, and on arrival you find the owner of the business who states that he was coming in to open up his store for the morning when he noticed a pair of boots sticking out of a nearby snow pile. You remove the patient from the snow pile and find him to be an unresponsive 30-year-old man. He is ice cold to the touch. There is no apparent evidence of trauma on your initial exam. While his airway is unobstructed, he does not appear to be breathing, and no pulse is palpated after 10 seconds. His entire body is stiff. Some questions to consider for this patient. What are indications to withhold CPR or start CPR in a hypothermic cardiac arrest? How is ACLS different in hypothermic arrest? If this was a different case and the patient was conscious, would it be safe for him to stand up and walk himself to the cot? And when should rewarming start in hypothermia and how should you do it? This is a case of severe hypothermia and potential cardiac arrest. Hypothermia occurs when the body's core temperature drops below 95 degrees Fahrenheit, leading to progressively worsening neurological and cardiac dysfunction, followed by abnormalities in multiple organ systems and in severe cases, cardiac arrest. As with hyperthermia, getting an accurate temperature in the field can be challenging. While a normal temp on an oral thermometer is probably good enough to rule out significant hypothermia, as with hyperthermia, rectal temperature is the gold standard. Though of course you should not expose the patient to the elements to obtain a rectal temp, only do this once they're in the nice warm ambulance. Again, it's important to know the functional range of the thermometer that you're using. For example, in the OSU emergency department, our normal rectal thermometers don't actually go below 94 degrees Fahrenheit, and so will show an error for a truly hypothermic patient, requiring us to track down a different technique to obtain a true temperature. Difficulties with obtaining an accurate temp in the field means that initial resuscitation efforts will likely be based on a history of cold exposure and on the symptoms that the patient is presenting with. Most professional societies do recommend using mental status and shivering to help guide initial resuscitation, but again, recognize there can be significant overlap between presentations and temperature ranges. So, if history and presentation are concerning for hypothermia, but you're unable to get a temp, treat them like hypothermia using the symptoms to guide you. For the evaluation and management of hypothermic patients, I like to use this algorithm that I pulled from the 2019 Wilderness Medical Society Clinical Practice Guidelines. I like this algorithm because it essentially aligns with other guidelines such as those released by the American Heart Association in 2005 and the European Resuscitation Council in 2021, but it's designed specifically with the pre-hospital setting in mind. Starting at the top of the algorithm, as with all things in EMS, scene safety and BSI. Hypothermic patients need to be handled gently, and we'll talk more about that in a sec. Don't forget to consider other causes of the patient's presentation. For this talk, we'll be focusing exclusively on hypothermia, but trauma patients and MIs still need specialized care, even if they are hypothermic. The classic example of this would be an elderly person who fell in the middle of the night and was lying on a cold floor. The cold floor caused them to be hypothermic, but the trauma from their fall also needs to be addressed. The evaluation of these patients starts with assessment of mental status. If your patient has a normal mental status and is able to care for themselves, whether or not they are shivering, it is unlikely that this person has hypothermia. It's even possible that you can confirm a normal temp with an oral thermometer for this patient. This group of patients just needs to come in out of the cold and will be just fine. However, if your patient has a normal mental status but is shivering and not able to care for themselves, then suspect at least mild hypothermia. A conscious patient with altered mental status, with or without shivering, would be concerning for a moderate hypothermia. Both these categories are treated similarly, with more aggressive treatments utilized for more severe hypothermia. While it's great to tailor your therapies to their actual core temperature, it's very possible that you will not have a thermometer that can measure accurate temperatures in these groups. Patients with mild or moderate hypothermia require rewarming. Get them to the back of the ambulance, protecting them from the elements as much as possible on the way there, and turn the heater on as high as you can stand. Remove any wet clothing and cover them with warm blankets as much as possible. In general, these patients should be kept horizontal and as inactive as possible. Even if they can walk to the ambulance, they should be carried on the stretcher instead. The reasoning behind this is a concern for something called afterdrop. This is when very cold blood that is pooled in the extremities is pumped back to the core by activity and movement of the extremities, leading to worsening core temperatures and increased cardiac stress. I kind of rolled my eyes when I heard about this for the first time as well, but core temp drops as profound as 10 degrees Fahrenheit have been recorded, and numerous cases of cardiac arrest precipitated after a hypothermic patient is allowed to exercise have been reported as well. For similar reasons, active warming with heat pads should focus on the core. Heat packs should be placed on the back, chest, axilla, neck, and head, with care taken to prevent direct contact with the skin, as these patients are particularly vulnerable to burns. Extremities should otherwise be left to passively warm. If extremities are preferentially warmed, this leads to vasodilation, which allows for return of cold blood to the heart and can destabilize the patient, just as when they exert themselves. The patient should be left horizontal until they have been actively rewarmed for at least 30 minutes. For patients with moderate hypothermia or worse, as we've just discussed, the myocardium is very irritable and prone to going into arrhythmia, such as ventricular fibrillation. It's reasonable to place these patients on defibrillator pads and to continuously monitor the heart rhythm and vital signs during transport. It's also reasonable to obtain IV access and give warm fluid boluses to these patients, as they are at higher risk for intravascular depletion due to the vasoconstriction they've been experiencing. If you're unable to obtain an IV, an IO can be used, but this would only be necessary if the patient was unstable or in extremis. Presses are less effective in hypothermic patients and can predispose to arrhythmia, and so should only be used for patients that are persistently hypotensive with MAPs less than 60 that don't improve with fluid repletion and rewarming. Finally, you should always check the glucose in these patients. Shivering burns a lot of calories, and especially if it's been prolonged, they're highly likely to have hypoglycemia. In a patient with altered mental status and concern for hypothermia, if you're unable to obtain a point of care glucose reading, it's reasonable to give IV dextrose empirically. Now we're moving on to more severe hypothermia. These patients are often unresponsive, just like the patient that was found in the snowbank from our case. These patients require all of the interventions that we discussed previously for mild to moderate hypothermia, including active rewarming, IV access, point of care glucose, etc. In addition, these patients should be carefully checked for any signs of life, respirations, pulse, and other vital signs. If they can be detected, they should undergo care as discussed before and be transported to a hospital, preferably one with the ability to do ECMO, as these patients are at high risk for destabilization and ultimately cardiac arrest. If there is evidence of respiratory insufficiency, concerns about airway patency, or cardiac arrest, the patient should be intubated. While historically there have been concerns that intubation might lead to VFib or VTAC, given the irritable myocardium of the hypothermic heart, more recent studies have suggested that this is exceedingly rare and that the benefits often outweigh the risks. Ensure that the patient is adequately preoxygenated and recognize that there is a risk that even paralytics may not be able to overcome a frozen shut jaw. Consider a supraglottic airway if you anticipate difficulty or if you are unable to intubate. End-tidal CO2 is likely to be lower than you're used to in a non-hypothermic patient, but a waveform is still indicative of appropriate tube placement. In general, the rate of ventilation should be about half that of what you would use for a non-hypothermic patient, i.e. a breath about every 10 to 12 seconds. This prevents hyperventilation in the setting of the decreased metabolic requirements of hypothermia, and again, end-tidal CO2 can be used to guide you. What about our patient who has no signs of life on initial assessment? Here we'll get into a few important differences between ACLS and management of hypothermic arrests, recognizing that the data are somewhat limited here and that much of this ends up being based on expert opinion. The first point of departure from ACLS is the amount of time given for the pulse check. In hypothermic patients, 60 seconds is allowed for assessment of pulse and respirations, and if at all possible, cardiac monitor and end-tidal CO2 should be used as well during this time. If that makes you uncomfortable, you're not alone. However, there's a good reason behind this prolonged time. For every 2 degrees Fahrenheit that the temperature is reduced, the metabolic requirements of the body drop by about 6 to 7%, and probably much more than this in the brain. This means that these patients are protected from neurological damage even if they are in full arrest. And this is the explanation as to why the rate of survival to hospital discharge with good neurological outcome is so high in these patients. There's a case report of a patient rescued from a crevasse in the Alps after being trapped for 5 hours, initially found to be in cardiac arrest, who underwent no CPR for the 70 minutes it took to lifeline him to the hospital, who ultimately went on to have ROSC and complete neurological recovery after they started CPR when he got to the hospital. So these patients can tolerate a little longer pause before CPR is initiated. Additionally, pulse and respirations will naturally be slower in these patients, and significant vasoconstriction and chest wall stiffness makes them much harder to detect. It's recommended that whenever possible, these patients are rapidly hooked up to the monitor and end-tidal CO2 to help identify possible perfusing rhythms. If a non-perfusing rhythm such as ventricular fibrillation, ventricular tachycardia, or a systole is identified on the monitor, CPR should be initiated. EEA is a little bit more challenging to manage, as differentiating true pulseless electrical activity from a perfusing rhythm with undetectable pulse in the setting of the challenges we just mentioned is hard. And the irritability of a hypothermic heart means that the risk of starting CPR and turning a potentially perfusing rhythm into ventricular fibrillation that's hard to convert is very real. If there's any evidence of life in a patient with PEA, especially if there is any waveform on end tidal CO2, even with relatively low values, this is likely a perfusing rhythm. Don't start CPR, but monitor very closely for degradation into a non-perfusing rhythm such as VFib that might require CPR. If PEA and no end tidal CO2 waveform or other signs of life, then CPR should be started.
You've probably heard the phrase, no one is dead until they're warm and dead. This refers to the fact that many findings that are considered definitive for death in other settings, such as fixed dilated pupils, apparent rigor mortis, dependent lividity, can be seen in a severely hypothermic patient in apparent cardiac arrest who goes on to have a full neurological recovery after ROSC. That being said, if a patient has something obvious like a decapitation or a torso transection, CPR should not be initiated. A chest wall that is not just stiff, which certainly can happen in a hypothermic patient, but truly frozen solid to the point that it is uncompressible, is also an indication to withhold CPR. While I think this is totally reasonable, I'd probably be a little cautious with this particular category. Our ability to say if the heart is truly frozen solid and so not salvageable versus just a truly frozen chest wall in the field is pretty limited. It's very reasonable to withhold compression since we're saying by definition they have a non-compressible chest anyway. However, I would still put them on the monitor and look at what rhythm they're in, put them on end tidal, monitor for signs of life or rhythm change, and transport them to the emergency department. And there they can do a more detailed assessment before they definitively call the code. Of note, there is no temperature cutoff for initiating CPR in hypothermia. The lowest core temperature recorded for a person successfully resuscitated is 56 degrees Fahrenheit.
Once you've determined the need for chest compressions, they can be initiated in the same fashion as you would for any other arrest. It's okay to use a Lucas device or similar, and to use the typical rate. However, in another departure from normal ACLS, the appropriate algorithm for shocks and meds changes based on core temperature. If the patient has a core temperature that's less than 30 degrees Celsius or 86 degrees Fahrenheit and a shockable rhythm, it is reasonable to attempt one shock, as successful defibrillation has been reported at temps as low as 26 degrees Celsius. However, if this initial shock is unsuccessful, it is best to withhold additional shocks until the patient is warmed above 30 degrees Celsius. The AHA, Wilderness Medical Society, and European Resuscitation Council all recommend withholding meds in patients with a temp less than 30 degrees Celsius, as they don't have any effect at these low temps and can build up to toxic levels due to changes in metabolism and ultimately cause the patient trouble once they are warmed again. If you do decide to give meds at less than 30 degrees Celsius, which is allowed by the MEC protocol, they should be done at half doses and only done once. For a core temp greater than 86 degrees Fahrenheit, the patient receives shocks as they would in standard ACLS. The AHA, WMS, and ERC algorithms all suggest that meds should be given at twice the normal interval, i.e. half as often. In the MEC protocols, meds are given at the same intervals, but at half doses. If the temp has returned to greater than 35 degrees Celsius or 96 degrees Fahrenheit, then ACLS should proceed as per normal. If the core temp is unknown, it leaves you in a tough spot as to how to proceed with ACLS. Ultimately, you'll need to use your judgment based on how you found the patient initially to estimate likely core temp, recognizing that too much epi will harm the patient and defibrillation at very low temperature is likely to be unsuccessful until the patient is more warm. Finally, if at all possible, hypothermic patients with hemodynamic instability should be taken to an ECMO center like OSU, as this results in the best outcomes. Before I finish up here, I'm just going to touch briefly on frostbite. You're most likely to encounter this in patients with a more chronic cold exposure, for example in homeless populations or those who have been down in the cold for a long time. It affects mostly the hands, feet, and face, and in the acute phase prior to rewarming, these areas appear like those shown in the pictures here and are completely numb. These patients should be moved to a warm area as soon as possible, with rewarming of the affected limbs delayed until there is no further risk of cold exposure, as refreezing can further damage the areas. If you do start rewarming, it should be done slowly, for example by using the patient's own body heat, having them put their hand in their armpit, that sort of thing. Rewarming can be excruciating, so addressing pain is needed while the patient is being transported to the hospital. Thanks so much for letting me talk to you guys today. I know that we touched on a lot of different topics that you probably haven't thought about for a while, and you probably have questions. If anything does come up about the topics we touched on today, please feel free to reach out to me, and my email address is on the screen. Otherwise, wish you guys the best. Stay safe out there.